I have Dr. Thamboo doing a presentation, and he is going to have Dr. Warren Mullings present with him. So we're going to put him on the spot. So Dr. Andrew Thamboo is an associate professor at UBC. He is one of the VGH sinus and skull-based surgeons working with the neurosurgery team in managing anterior skull-based tumors, such as pituitary tumors. He has recently been recruited back, yes, from the US, Stanford, and currently serves the Vancouver and Fraser Valley population. Dr. Warren Mullings is an endoscopic and skull-based surgery fellow. Is it fellow or fellowship?
Fellowship.
Fellow at the St. Paul Sinus Center. He is from Jamaica and works closely with Dr. Amin Javer and Dr. Andrew Thamboo. Upon completion of his fellowship, you're not allowed to do this, by the way, he plans to return to Jamaica to establish a rhinology practice that serves the Caribbean region. I wish you the best of luck in your journey. Thank you for coming and presenting.
Thank you.
Okay.
Thank you.
All right, thanks, Deanna, for having us. I'm excited to be here. I know, I think we're the first time a rhinologist has come to a conference like this.
We've only had Dr.
Acromegaly
come and present
Yeah.
our support for you.
Awesome. And I think, obviously, a lot of you guys know Dr. Acromegaly. He's like a samurai. He's like, you know, he's the godfather in this area. And
He's very worshipped.
he's very worshipped. And I've got the lucky opportunity to work with one of his colleagues. And Dr. Gooderham and myself and Dr. Arif Janjwa, we kind of do it from the endoscopic approach. So I'll give you a full disclosure. I'm an endoscopic sinus surgeon. Therefore, I'm biased, and my viewpoints come from that standpoint. I've got Dr. Mullings presenting this with me. He's going to be driving actually this presentation, and he's actually going to be the first Caribbean sinus skull-based surgeon there, and we're really proud of what he's accomplished this past year. And we're going to obviously miss him, and he's learned a lot. And he's put, you know, like all fellows, they do a lot of work for their staff guys, and they put all these videos together and these pictures together, and I thought it would be obviously a good opportunity for him to present this. So keeping this relatively informal, I'm also going to interject at times to also provide some of my thoughts as well on this talk as well. So with that, I'll let Warren start his presentation.
Thank you so much for giving me the opportunity to come and present some of the things that we do as sinus surgeons.
Yeah, it's a PDF.
Oh, where's the little clicker?
Yeah, that's the PDF. I think we need a PowerPoint.
Oh.
Of course, this always happens to the fellow as he's about to present. So as you all know, this condition is really a hormonal disorder caused by the overproduction of growth hormone from the pituitary gland. I believe the lower one is forward. Right. The pituitary gland is unique. It sits at the base of the brain and at the back of the nose. And that creates challenges, but also opportunities. It's challenging to access in most ways, for example, craniotomies, but certainly Dr. Acromegaly is skilled at this. And it also provides an opportunity for us to access it through the nose. But the nose is particularly important in assessing danger, for example, fire, toxins that we may be exposed to. So it's important for us to maintain its function. So it's not only a conduit, but actually serves important functions to protect us against these dangers. It humidifies the air, it cleans the air, it warms the air, and it's actually an important immunological defense. So the tool that we use is the endoscope. It's a small metal rod. It's about 3 millimeters in size to 4 millimeters in size. And we pass it through the nostrils, and we get a magnified view of the structures within the nose. we can pass it all the way to where the pituitary gland sits. Accessing the pituitary via the nose is not novel. It actually had occurred all the way in 1908 and was published in the New York Times, where they had the big headline, "Acromegaly Cured." So when we pass the endoscope into the nose, we're able to see structures on the right and on the left. On the right is what we call the septum. It separates the right side from the left side. And on the left, there are these undulating structures which are known as turbinates. At the top of the turbinates are the smell nerves. The turbinates themselves have lining over them that warms the air and cleans the air. So it's very important during surgery to preserve these structures.
Actually, Dr. Mullings, do you mind going back? I just want to show them that video again. I think this is important for you guys to really appreciate the notes. I mean, again, biased opinion. Because this is exactly what we're trying to maintain, and this is where I think where rhinologists get involved at times for these cases. This is what the turbinate is. That's the turbinate, that's the septum, and so that's the middle turbinate, and then we're going into the superior turbinate. And these are the structures that humidify your air, they provide filtration, and they also provide smell. And those are actually really important things for when it comes to quality of life. You know, we're obviously taking a tumor, and that's the primary goal of this resection, but also there's a quality of life aspect. And when we're doing this approach, you know, your surgeon is extremely vigilant about these structures. So when we're going through the nose, we're just making sure we don't damage those.
Thank you. So this is a still picture showing the septum on the left and the turbinate on the right, as well as the nasal floor. As you go a little bit higher, you'll realize that there are a number of turbinates. There's the inferior turbinate, the middle turbinate, there's a superior turbinate, and just behind the superior turbinate is actually the sphenoid sinus. The sphenoid sinus, and at the back of the sphenoid sinus is where it sits the pituitary gland. At the back of the nose, there's actually the eustachian tube, and that's the tube that connects the air to the back of the nose. And therefore, many times you may have sinus issues and you're wondering what my air is affected, and that's because this tube is affected at the back of the nose. So this is where the action occurs. At the sphenoid sinus, at the very back of the nose, once you pass through this little dark passage here, you can have a direct view on the pituitary gland. Now, once you're looking at the pituitary gland, to either side are the major vessels to the brain, the carotid, and therefore it's an important anatomical landmark to be aware of because you can inadvertently injure them if you're not aware. So it's particularly important that you are always aware of where you are doing the surgical procedure. Now, this is only about 7 to 9 centimeters from the tip of the nose and about 30 degrees up. So what do you expect before you head to surgery? You're certainly going to be seeing your surgeons and your endocrinologists previously. You're going to likely, as Dr. Acromegaly said, stay in hospital for 2 to 4 days, or 1 to 2 days, depending on how things go. You're going to not eat the night before surgery, admitted on the morning of surgery, depending on the protocol of the hospital at which you're going to have your surgical procedure done. You're certainly going to be seen by your surgeon in the morning and marked, and there'll be a discussion if there needs to be. You'll be carried to the operating room, that is, and then you'll meet everybody on the team. And this is certainly a good opportunity for you to get to know everybody, to say hello, and to ask any further questions that you may have. Now, what do you do at surgery? Just after lunch, perfect video. So we're actually going to make a hole in the back of the septum. It may look a little aggressive, but trust me, you don't feel anything. You identify the bone which separates the right and the left side of the sphenoid sinus, and you remove it gently. And once it's out, once it's compliant, you'll get to the back of the sphenoid sinus. And just above that area that we were suctioning is the pituitary gland. Now you're going to pass a small instrument and gently crack that bone. Believe me, you don't feel it. And then once you've successfully created that opening, you're going to gently lift the bone up. This is really a millimeter. This kerosene, or this device that we use to hold that bone, is only a millimeter. So this is microsurgery almost. That's bone. And then behind that bone, is the lining around the pituitary, that's the meninges, and then we make a small cut in that area, which you'll see now. And then once we make a cut, we'll see the pituitary gland bulge right behind us. There it is. And so we can actually begin the process of removing abnormal tissue within that pituitary. And so we do this carefully, being cognizant of the major vessels that are beside us and the nerves which are above us that control our vision.
And hopefully you don't have the shakes, right?
Exactly. It's very important to be very stable. So once you're in, you're able to remove the abnormal tissue, and then you actually reconstruct with bone. This is the technique that we use as endoscopic surgeons.
Is there a suction on the end?
There is a suction on the end of this particular device, yes.
So then do you guys switch on?
Yeah. So
Yes.
Yeah, it's a good question. So like when we were talking with Dr. Acromegaly, he was talking about the right nostril, like, right? Is that correct? That you usually go through the right one nostril. Now, when we're dancing with a neurosurgeon as a rhinologist, we do a two-nostril approach, and in doing so, we're there all the whole time. So I tell everybody we're the expensive limousine drivers. Okay, we're gonna get the neurosurgeon to that area. The neurosurgeon then takes over at a certain point. He takes out the tumor. We provide the visualization so that he can remove the tumor, and then we kind of help with the reconstruction thereafter.
So the first patient for which you did this all on your own, how did they get selected?
All on your own.
And how did they make up?
Well, yeah, I think, good question. So back where we did it, that's in California, we would do 6 in a day. So I think it's just a different system. You ran 2 ORs. So when I came back here, you feel fairly comfortable coming to a system where there's only 1 OR that you run. It's just a different system. And you're just comfortable after a while doing these cases.
Well, I know after a while.
Yeah. I mean, that's the beauty of medical training, to be honest. It's the beauty of medical training that you work with senior guys that get you to a level where you feel comfortable, and then it's time to take over the reign as well. So.
Well, so the advice commonly is go with the surgeons who have the most experience.
For sure.
Yeah.
Not the least.
Yeah, great. I agree. But there comes a threshold where your skill set is safe and you have the ability to remove the tumor completely, comfortably. So, yeah. But it's all about volume. Correct. I agree. Volume.
So certainly, when you don't have a CSF leak, which was spoken about earlier, we reconstruct the area at the back of the sinus with your natural covering for that sinus, which we had preserved at the beginning. And shortly, what you'll see is that we'll lift the lining of that sinus that we had just preserved, and we'll put it back. So at the end of the case, you look as if nobody, as if there was minimal interruption to the region. However, if you do have a CSF leak, which can happen while doing this procedure, we actually use what's called a flap, which basically means it's your natural tissue with an established blood supply. And we use the septum most commonly. And so we make cuts along the septum, which separate the right from the left side, and we lift that lining up and we put it towards the back of the nose. So in this video, you'll see that we'll make those cuts and then we'll lift up that lining of that septum. And that septum is primarily cartilage, as well as there's a little bone towards the back of it. And once we've successfully elevated it all the way to the back, we put it into the nasopharynx, or the back of the throat. And then the pituitary gland actually sits just in here. So in this video, we'll demonstrate to you that we can now establish good visualization. Everything is nice and open. We take that flap with this established blood supply, and we actually put it within the sphenoid sinus. And we patch the area that would have had the CSF leak behind. So we make sure that we put it against tightly, that you take out any air pockets which may be there. And this is the glue that we put around the flap, which was spoken about earlier, to create that watertight seal. And then within that area, we put some dressing. So we don't pack the nose, because most of our patients, or all of our patients after this particular procedure, will be able to breathe. And they'll not be aware that there's anything in the nose. But we put a little dressing along that area to make sure that it's nicely sealed and prevents any more fluid from coming out.
And what drives this decision for us in terms of me raising a nasal septal flap is actually my neurosurgeon I work with, Dr. Durham. He prefers this, and I'm happy to do it, this approach. And he hasn't had a CS, he hasn't had a CSF leak for 2 years. So this is something that drives his decision making, and then I provide that service as a technician to raise up the nasal septal flap right there.
One of the most common things that patients experience after this particular surgery is headaches. And usually this is well controlled with minimal amount of analgesia. But certainly we work with our neurosurgeons, and if this headache is out of characteristic than what you'd expect, then certainly we may need to do images to make sure that there is nothing adverse happening at that time. There is a hospital stay that we spoke about, but the patient will be able to breathe through the nose. There may be some nasal congestion. There is swelling to the lining of the tissues, and that's the congestion that was spoken about earlier. You may have a little bit of oozing, but certainly you'll be monitored closely, looking at your urine output and your brain function after surgery. This on the right-hand side shows crusting, which can happen in the nose after operating, particularly when you're lifting up a flap. That's why it's essential that you keep the nose moist after surgery. During the first week after surgery, you use mist, saline mist, which just keep the area nice and moist. And then after that period of time, then you'd be able to rinse. And that reduces the amount of crust, which can obstruct the nose and give the feeling as if you can't breathe. It's important to not do any heavy lifting, certainly up to the first month after surgery, as this will potentiate the risk of you having a leak. Misting we spoke about, and certainly to keep in contact with your surgeons and your endocrinologists. Repeat scans may be a part of your management, certainly not necessarily in the immediate post-operative period, but certainly a little delayed, as well as visual testing, as your vision may have been affected by your tumor, and you want to see if there's any changes there, or the surgical procedure, and therefore you'd have to evaluate whether or not that has been affected. The risks we spoke about, CSF leak, meningitis, as so well spoken about, are potentiated just because we're operating in that region, and so there are things that we have to watch out for and look out for and make sure that we manage if it does occur. You can have damage to normal areas, and that's the reason that we are monitoring your urine output to see whether or not you have a condition known as diabetes insipidus. Severe bleeding from injury to the blood vessels is important to watch for visual problems. And certainly once you have successful surgery, the mucosa within the nose will heal nicely and look similar to how they looked prior to surgery.
So I think I think for the post-op care, at least as a hand of a rhinologist, is we're just again anal about it. We want that nose to be essentially. I like to say we're guests in the nose. Okay, so the nose is a conduit. The problem is in the brain, right? So I want to minimize what's happening in the nose. So the post-op care to me is actually really important. And I if I talk to a lot of patients, the morbidity of the surgery is not up there; it's actually in the nose. It's the approach that we do. So I think I see patients a week after surgery, 3 weeks after surgery, and then at least one more time, 3 to 4 months after surgery, just so we optimize that nose so we don't develop any problems.
So we're ahead of the game here. Has anybody got any questions? Garnett's coming in.
Yeah, I'll just have to turn off
We're
the
still going to have a
doctor's
question
notes.
panel from 4 to 5. So if you don't get your question answered, there's still the question panel later on.
I have a question.
Sure. Okay, that's after my
So I know that you had said that you would prefer to take cartilage if you have a CF leak.
Yeah. Yep.
Okay.
Potentially.
Now, is it just a personal preference to take the adipose tissue from the belly versus the cartilage? Because when I had my surgery, they used cartilage,
Mhm.
but when I woke up, my belly was cleaned just in case they needed to take it. So is it just depending on the size of the CF flake, the surgeon?
We prep for everything. So we prep for belly, we prep for fascia potentially, and obviously when we're in the nose, we have options to include for surgical closure. If there's when we're doing our approach and we take out some tissue, sometimes we use that tissue that we've already taken out to replace, and that's what's happened in your situation. So, but we use fat usually in the sense that the surgical defect site is kind of large, and we put the fat in there, and then we place some type of closure.
Well, that was easy.
Just curious, when you do other surgeries on regular people who don't have acromegaly, do you notice physiological difference
Definitely.
in the
Yes.
nasal septum and the growth?
Especially in acromegaly, that bone is very hard. You tend to have a lot more bony spurs, which are like more deviated septums. So one of the benefits potentially, when you see us prior to surgery, is that I look in the nose and I say, hey, how's your breathing? How's your nasal breathing? Like, are you affected by it? I show you on a camera how your nose looks like. We discuss and talk about whether even addressing that septal deviation at the same time as we do our approach for the pituitary, again, to optimize your post-op.
That's great, thank you.
And Cushing's, same thing. I think those are also harder cases.
So then it's just bone, it's not soft tissue changes that you see?
But we appreciate as well. Yes, as well.
What about your ability to smell things after surgery? In my case, and I think it's gone down significantly. Does that sound familiar?
So I think that varies. I think, again, it's the approach. I think we showed you a picture of turbinates. We mentioned the words middle turbinate, superior turbinate. The olfactory fibers sit on primarily on a structure called the superior turbinate, okay? And what we do is we call outfracturing. So we take a structure that's a superior turbinate which sits in this vertical plane, and we push it to a side. We find this hole that goes into your sphenoid sinus, and we open it up. So that structure that you're talking about that contains that olfaction, we keep that intact, okay? However, obviously the approach can cause inflammation, etc., in that area, which can obviously damage nerves. So that's why there's always that risk, okay, of damaging olfaction. And that's why I think I come back to post-op care in that area, because by decreasing the inflammation in that area, over time, you're not going to potentially have loss of smell. Okay, there could be other factors as well. You could also be developing chronic sinus disease, like that trying to figuring out why you're losing smell over time involves an investigation and understanding what's going on. So nasal steroids are kind of like the basic standard treatment initially to start with, and kind of going from there.
In my case, I got more sense of smell. It's very sensitive. So is that kind of the opposite of his?
It's the same thing. So in terms of you have the nerves in that area, and again you're manipulating that area, and when you damage mucosa, the mucosa in that area has nerves, and usually they regenerate. Okay, but sometimes they become hypersensitive, and that's maybe in the situation to you. And some other patients, they become hypofunctional, and then people have loss of smell.
What about dry nose? Is
Yep.
that a common side effect of the surgery?
It can, not a common side effect. It can be, and that's because, again, there was never intention by God for us to make these holes, right? Right? We are changing the natural physiology of your nose by doing any approach, by getting there, right? And by your natural conduit of air is to go from through your nose to the back of your nose. And now what's going to happen when you open up that area, it causes airflow to go into that area of where your sphenoid sinus is. And you can cause turbulent flow. And turbulent flow is what causes potential dryness. Now again, I also do sinus surgery on patients for inflammatory conditions, and we do open those sinuses up. So in general, those patients do really well, but they can also complain of dryness potentially.
So what would you recommend to?
Keep it moist.
Right.
Mist, saline irrigation are like a very common thing. If it's in the front of your nose of dryness, then it's kind of a water-based gel, called nasogel, are all products you can get over the counter.
Would you ever
Oh yeah, so her question is whether to put Fusidin or some kind of antibacterial ointment in your nose. Sometimes initially after surgery, and that's kind of the crusting issue. If I feel that the crusting issue has a bacterial component to it, we sometimes put like some kind of Fusidin or something. But that's again more of a rare thing than a common thing.
So I live in a dry climate,
Yeah.
and my ENT tells a lot of his patients just to do that in the wintertime,
Yeah.
even once you're healed. So
Yeah. So again, I guess again. Depends how you look at it. If you're talking about a dryness issue, it's not it's not a bacterial issue, and I would really strongly suggest that you don't use a antibacterial ointment, because that you're just exposing yourself to potentially, being resistant to a bug in your nose. Whereas using a water-based gel, which provides the same service of keeping your nose hydrated, does that better.
So the hole that I have in my nose, is that from, because they put a hole in from left to right? So is that what they used to plug my second CSF leak or my first CSF? I had two, right? So
Yeah.
is that where that piece is from?
I mean, I'm not sure about your situation, but I assume they take a nasal septal flap.
Okay.
And when you do a nasal septal flap, that picture you saw where we're elevating mucosa off the cartilage, there's mucosa on the other side. So technically, that donor site where we raise that nasal septal flap, it will remucosalize over time.
Oh, so
Okay.
the hole close up?
The hole closes up, or the donor site where that flap was elevated, it will remucosalize and make that new nasal mucosa again. However, if the other side is also damaged, then you end up potentially with a hole. So.
So, can scar tissue cause issues with your eardrum? And having water back up and it's not draining down your sinuses?
Can scar tissue, I mean, that's rare for scar tissue to be actually where your eustachian tube is. And so Dr. Mullings showed you a picture of the back of the nose. You saw a picture of the eustachian tube going up, and we talked about there's a connection. There is definitely a connection between the nasal cavity and ear symptoms. We talk about ear fullness, and you may get ringing, or you may feel like you got fluid back there. There's a recent study that came out of Stanford where they talked about patients who've had sinus surgery and whether that changes their ear symptoms, and that didn't show anything, no difference. So they didn't show any correlation between doing anything sinonasally for surgery and change in ear symptoms. But do we hear concerns that your patients talk about that you have? Yes.
Well, it's not like it's not big stats,
Mm-hmm.
but there are stats crawling up where our ears will fill up and all of a sudden the water just bursts right out, and it's like a tap coming down because the water has been so backed up behind the eardrum, and we continuously have ear issues. Now, I've been told it could be because the bones are growing, or it could be because there's tissue damage, not damage, but scar tissue, or maybe the bones are growing and it's causing our...
So that's a different situation. That's not
close.
surgery. So that's not from surgery, actually. That is just this secondary to the disease process, likely, potentially. So that tube we talked about, that eustachian tube. Okay, naturally, its natural function is that you may create fluid. You also create air pressure within the middle ear space. Okay, the eustachian tube opens and it releases that into your nasal cavity. Okay, I guess then what you're saying is a situation where that eustachian tube is dysfunctioning. It's not working properly. Therefore, it's closed, and you create fluid in your middle ear space. And one way it can only go out, if it can't go into your nasal cavity, is to actually exit through the eardrum, and that's kind of what you're explaining.
Yeah, but it's not just like this is something that like I said, there's not a massive percentage of us, but there is, I would say, probably about 10 to 20% percentage of acromegaly patients that deal with this issue.
Yeah.
How do you fix it? Because it's really annoying when you're talking and your eardrum is like, it's like an echo,
full. Yeah.
and you're in pain because you got ear pain, which is obviously already painful, right?
Two things will happen. One, natural course of what's going to happen, which is it's going to make a hole, which will obviously relieve the pain. But what the second thing you can actually do is see an ENT doctor, and they can put a tube in the.
So how do you convince your ENT that this needs to be done when they're not seeing anything?
So
This is what we do go through as an acromegaly patients is we have to keep going back
Yeah.
to get them to realize that, yeah, this is probably because our bones are growing and
Mhm.
there is a problem, even though you're not seeing it on your scans, right?
Yeah, so way we diagnose fluid in the ears is two ways. One, examination by looking with our otoscopes into the ear, but the second thing is we do a hearing test. And with that hearing test, it's something called a tympanogram, and we look at the hypermobility of your tympanic membrane. And that tells us whether you have fluid or not. Sometimes it really actually is hard to like make a diagnosis of fluid behind the ear just by looking with our otoscope. So sometimes the addition of a tympanogram will help in that diagnosis. So.
Maybe we got time for one more.
I don't.
I know your colleague, Dr. Janjua, who also operates with Dr. Gooderham,
Yeah.
seems to be leaving nasal stents in place after surgery. So I was wondering if you do that, and if so, how long the stents stay in place?
So there's different ways to manage. So the stents that we're talking about are the stents that we place on the septum. And the reason we place it on the septum at times is because when we raise that nasal septal flap, we have this exposed donor site, okay? And what we want to do from a rhinologist standpoint, again, is we want that donor site to remucosalize. The quicker you mucosalize, the decrease in crusting, the better you guys feel, okay? Now, there are a number of ways to do this. One is placing silastic, and the theory behind placing silastic is that it creates a water environment between your cartilage, that donor site, and the silastic to recreate like mucosa. Hopefully it enhances it, it makes it faster. The literature isn't out there on that, to be honest. Again, that's just based on our experience. What is actually out there that shows that increased enhancement is actually a product called Biodesign. It's a pig gut intestine that you can place up there and then place silastic, and that actually improves epithelialization. So in my practice right now, I'll put silastic just based on my practices, because how we work as a team, we just keep, everybody operates the same, we just do it that way. Back when we were at Stanford, if we weren't using Biodesign, we were going to use nothing, because the evidence there was no addition benefit in terms of mucosalization. So when we do place a stent though, we take it out after 7 days. So we see everybody after a week, remove those stents, clean out the nose, and we kind of go from there.
Dr. Janjua did mine, and I had them in for over a month.
Oh, interesting. Yeah, it has to be a certain reason why that situation happened. It's hard for me to tell you.
Yeah, it was well over a month.
Yeah, when you have the celestial stents, and you probably could attest to this, you feel blocked. It feels like something's potentially there,
Yeah.
and he must have had a good reason to keep it there. So.
Somehow I missed the message that you're supposed to rinse.
Okay.
Even though it told out was worse than surgery.
Yeah.
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 Because it was like they were pulling my brain out.
Yeah.
Okay,
Thank you.
very
Thank
much
you.
for coming and
Thank you.
presenting. Oh, wait.